Send this link over there.
I'm also sending a what to do.
No, we are sending another link.
Okay. Yeah, but that's going to be a big problem for people who
And we'll be sending all the people for another link.
probably not going to see this.
Oh, what?
But anyway.
No, we are sending another link.
Yeah, but that's going to be a big problem for people who
And we'll be sending all the people for another link.
probably not going to. Where's that chat now?
And WhatsApp link.
Yeah.
And we'll be sending all the people for another link.
Where's that chat?
Did you saw that open?
This, you can just, one second, click on share. See, this is just 3 watches. There's nobody from there over here. So this is the wrong link.
But he will finish fast. He'll come back.
Hello.
Now, how do you put it over there? Wait, I'll have to WhatsApp it.
No, don't bring anything here. Don't bring anything on the call.
He's on it. I don't have it on it.
Somebody has tweeted that they can hear everything what we talk on the link. I don't know. So we are live on YouTube. I can see. We are live on YouTube.
There's your phone.
But now it's live on YouTube.
It wasn't happening.
Oh.
No one can see it.
And they can hear somebody's vote.
No, the volume is full. Anyway.
No. Quickly tell us what we can talk here. Nothing, okay.
Awan Dadi na. Yes, we'll wait patiently.
Shit, yeah. But I was so worrying about this. मैं इसलिए बोला डॉक्टर ने भी फोन पे करने को नरेश ने. Can you call Naveen Thakkar if possible? Naveen Thakkar Makar. Sarah, you can call Naveen Thakkar. I can give you the number. Shit, yeah.
She sent a new link.
ये सब हमारे गड़बड़ थे इसे.
There's a new link which will go to everyone.
Prateek, can you paste that link on the chat and the
I will.
YouTube and ask people to click on it?
I will. So I will actually.
So everybody can transfer to the new link.
Yeah. Yes.
You'll have to put the link in the WhatsApp also.
I'm doing it.
I'm waiting for them to come there.
तो आमा मुक्को बरसा.
Yeah. Put the link first.
Hello.
नहीं पहला फिर वो चालू तो कर ही दो ना. हिम्मत मुक्को बरसा.
Yeah. That I
We
do.
can do.
Link क्या?
I'm sending the link in the chat.
Sending in the chat.
Yeah, we'll have to post that link. So
I've got it sorted. I'm sending in the chat. It's sorted.
It's on.
I'm sending the link in the chat.
She's already sent it.
Sorry, please keep.
I've got it sorted. I'm sending in the chat.
So now, that's
I'm sending the link in the chat.
Keep on sending couple of times on the chat. Pratit, keep on sending couple of times.
Okay.
Okay, it's we are live on YouTube. Anil,
Yeah.
Please mute everyone. Mute everyone.
okay, we are live on YouTube. Anil,
We are already live. Can we mute everybody?
Mute ourselves.
Just say something. Thank you for waiting.
Thank you very much for waiting for this technical snag. But now we are through with this problem. I don't know. COVID is everywhere. It's giving trouble. Anyway, good morning, friends. Good morning to all my family physician colleagues across the country. A very warm welcome to the popular CME on the first Sundays of every month since 70 years from the Bombay Seaward Medical Association and Bombay Medical Union. I also welcome the members of all the participating associations and faculty to this webinar on monsoon and the menace of fever in the backdrop of COVID-19 pandemic. Fever, the most common symptom in our OPD, but you will all agree that the most difficult to deal with. Bedside clinical sense, appropriate investigations, logical thinking, judicious use of medication needs thorough understanding of art and science of medicine. And monsoon brings its own set of diseases, and the current teaching in trying times of pandemic COVID-19, any fever walking into our clinic is to be considered as COVID unless proved otherwise. So to discuss this dreadful combination, we have today with us the legendary master physician and greatest teacher of our time, Dr. Farooq Udwadia. And he's being accompanied by young and dynamic physician, Dr. Pratit Samdani. We have a distinguished list of faculty today. Dr. Jitesh Mehta and Arvind Patel representing IMA Mumbai, Dr. Bharat Kumar Bhatt, Preeti Bhargav from GPA Greater Mumbai, Pragnesh Vachrajani and Dr. Preeti Shankar Vachrajani from Ahmedabad, Dr. Preeti Shankar from Bangalore, representing Federation of Family Physicians of India, Dr. Nisha Kushlani and Dr. Paresh Joshi representing A Ward Medical Association, Dr. Naresh Shivdasani, Dr. Samir Kapadia representing the Bombay D Ward Medical Association. We have Dr. Kamlesh Shah, Dr. Jawahar Mukhatyar, Dr. Surendra Delia, Dr. Atul Mashru, Dr. Rushin Mehta, and myself, Dr. Anil Mehta from the Bombay Seaward Medical Association. We have a special invitee, Dr. Anirudh Kohli will be joining shortly. And at the outset, I would like to thank Dr. Jawahar Mukhatyar and other faculty members to prepare today's cases. Now I invite Dr. Vijay Khambati, the President of Seaward Medical Association, and Dr. Vibhakar Advari, the President of Bombay Medical Union, to formally introduce Sir Dr. Farooq Udwadia and Dr. Pratit Samdani, respectively. Over to Dr. Khambati.
Thank you, Anil. Good morning, sir. Good morning, Pratit, and all the invitees from various associations. On behalf of all the medical associations, I would like to pray for all the doctors and health workers who has lost their lives in the last 2 to 3 months in their fight against COVID-19 and offer our heartfelt condolences to their families. Dr. Farooq Udwadia, a name that will be written in golden letters in the history books of the medicine in India and the world. An academic genius, he was awarded a distinction in medicine at both the MBBS and the MD examination by the University of Bombay and was awarded almost every scholarship and every medal the university had to offer. He was also awarded the Prince of Wales Gold Medal and Dr. C.S. Patel Gold Medal in MD examination. He was elected a fellow member of Royal College of Physicians, Edinburgh in 1969 at the age of 38 years, the youngest Indian ever to be so elected. His outstanding achievements are unparalleled to this day, as is evident from the innumerable awards he has received. Prominent among these are the Padma Bhushan Award for contribution to medicine in 1987 from Republic of India, the Dhanvantri Award in 1996, Master Fellow of American College of Chest Physician in 1997. This award has been given to only 12 individuals in the world in over 60 years since the founding of the college. Honorary Doctorate of Science by the Banaras University in 2004. The Citizen of Mumbai Award by Rotary Club of Bombay in 2008. As an excellent orator and teacher, he has had many academic associations in India and abroad, the most prestigious being visiting professor to Brompton Hospital, London, visiting lecturer to National Institute of Health, Washington, visiting professor to PGI Chandigarh and Manipal, University of Chicago, the Mayo Clinic, USA, Postgraduate Medical School, London and Edinburgh. He has to his credit several books and national and international publications, chiefly in the respiratory medicine, tropical eosinophilia, tetanus, medical ethics, and critical care in medicine. It is my proud privilege to present Dr. Farooq Adwadia, a name that invokes respect to the point of reverence, a name that is synonymous with excellence, integrity, and inspiration. Thank you, sir, for being with us this morning. I would now request Dr. Adwaria to introduce Dr. Pratit Samdani.
Thank you, doctor. Thank you very much for this superfluous and very exaggerated talk. I'm grateful.
Welcome. Vivakar.
Unmute.
Okay.
Hello.
Yeah, we can.
Yeah, I'm Dr. Vivakar Adwaria, President of Bombay Medical Union, which is the oldest medical associations of our country. I have the proud privilege of introducing Dr. Pratit Samdani. Dr. Pratit Samdani, who has done his MD internal medicine and at that time achieved the second rank in Bombay University. He has been a gold medalist at FCPS medicine exam. He is an honorary associate professor of medicine and head of medicine unit at GT Hospital and Sir JJ Group of Hospitals, Mumbai. He is attached as a consultant physician in Chandi, Jaslok, Saifi, Bhatia and Kambala Hill Hospital. He has special interest in internal medicine. Because of the time constraints and the time lost in this technical snag, I will not go into his various other achievements, awards, and publications. And I invite Pratit Samdani for accepting our invitation and undertaking the responsibility of this webinar. Thank you.
Thank you.
Pratit Samdani, please.
Thank you very much. Okay, so I think our agenda for today is that we are going to do some presentation of cases, and we, Dr. Adwaria and myself, can discuss about the cases. The questions can be put up on the chat. They will be screened, and when at the appropriate time, we will ask you these questions. We will answer these questions. Slide number 1, Sarah. Sarah? First case. Okay, so let's begin. We have a 58-year-old American male expatriate who's a resident of Mumbai since the last 15 years. He comes with a history of fever, intense fatigue, body ache, and joint pains. The fever has been abrupt in onset and has been ranging between 100 and 103 degrees Fahrenheit. He also complains of severe headaches, specifically in retroorbital area. So whenever you have someone with a retroorbital pain, couple of infections or diseases should strike us. Chills and rigors lasting for a few minutes for about 4 to 5 times a day, minimal nausea, loss of appetite. He's otherwise a healthy and athletic young male. Urine was clear, he was adequately hydrated. Fever responded well to paracetamol. He had to take it about 3 to 4 times a day. The only positive history, he had a history of travel to the northern eastern part of India to Orissa about 5 days ago. Next slide. The patient was investigated on day 3 of fever when he came to the family practitioner's clinic. Dr. Jawad, thank you for the slides. Malaria and dengue were negative. Transaminases were mildly elevated at 110. Platelets were on the lower side at 134,000. WBC again on the lower side, 4,020. Neutrophil 60. Important point here is the eosinophil count was about 4.5 and the monocytes were about 6%. The fever disappeared after 3 days, but the headache persisted and the body ache still persisted. Patient claimed he was feeling better, and I probably think it was only because he was afebrile. There was no treatment in terms of anti-malarials or antibiotics given to this patient except for paracetamol. Next slide. After 3 days of being afebrile, the patient again had a fever spike of about 102 for 2 days. He also developed a diffuse erythematous macular papular rash on the trunk and extremities involving the palms and soles. The joint pains were polyarticular, migratory joint pains with involvement of the small joints of the hands and wrists. The CBC was repeated on day 7. At this moment of time, a dengue test was asked, which was negative, and a chikungunya serology was advised. The chikungunya, sure enough, from most of us who would have guessed, had come positive. The IgM was positive. Painful few days, and the spread over the next couple of months. He had to be referred to a rheumatologist for pain management. Next slide. So what do we learn from this slide? In this case, we learned that this young gentle, otherwise who has no comorbidities, had a travel history. He had a fever. We had fever for 3, 4, 5 days, then no fever, and again fever. It was like a saddleback fever. So a little higher fever, then no fever, and again fever, accompanied with joint pains and rash. The final diagnosis was chikungunya, of course. Can I ask Dr. Udwaria, sir, to just comment on this case and some takeaways and points that we could have missed while examining these patients?
No, I don't think so. Though, of course, a saddleback fever, as you well know, not typically, but not uncommonly occurs in dengue fever as well. So I think the diagnosis or suspicion of dengue was correct. Considering that the dengue was negative and he had severe joint pains, I think the next thing to do, of course, was test for chikungunya. Now, as you know, I don't know if you all know how the word chikungunya came up. Are you aware of that, Pratik?
Yes, sir. It's basically a word from Africa, which means bend like. So, because of the severe
upwards. It means bends upwards. It's from a West African dialect. And the important thing here, which I would like to stress because I've seen quite a few, is that the rash need not necessarily be maculopapular. It can be all sorts, including vesicular. And the other thing that you sometimes see with these people, which you don't see with other viral infections, is erythema nodosa. That's the odd thing that you should remember. And sometimes the rash persists, particularly in the lower limbs, the redness persists. If I can recollect this particular patient, he had severe redness, which almost looked like a cellulitis for a number of days. And it's not just the small joints. If, for example, you had a history of the patient finding it difficult to turn in bed, if you had, for example, a history of axial involvement, then you could have straight away said that this is not likely to be dengue, this is likely to be chikungunya. And like all viral infections, it must be remembered that they usually recover. But chikungunya has a pretty high mortality. There was an epidemic in Ahmedabad, if I remember right, sometime in the early 2000s, where 5,000 people died of chikungunya for the simple reason that sometimes these viruses, which look pretty harmless, can attack almost all organ functions of the body. And in this particular patient that I thought of, right now, he had a wife who also was positive for chikungunya. She recovered very well. But you won't believe it, after 7 or 8 days, she developed a transverse myelitis. I couldn't for the life of me understand why she should have a transverse myelitis. A polyradiculitis, a Guillain-Barré are well-known complications of almost all virus infections. But a viral myelitis is extremely uncommon. But when I looked it up, I realized that very rarely a few cases of transverse myelitis have been reported. So please remember, the lesson to learn is that though most viral infections are very similar, they have fever, they have joint pains, they have leukopenia, they have thrombocytopenia, they have invariably a mild rise in the liver enzymes, and they gradually go away. That sometimes they can be very vicious. And another thing to remember is chikungunya, I think, is the only tropical infection which is present also in the West. It has been present, it started in Africa. It went on then to India, Asia, Southeast Asia, affected Europe, and then affected the Americas. So it's a point worth remembering.
Thank you so much, sir. As sir says, at one point of time, there was almost 50% of West African population that was affected with chikungunya. Just to reiterate and summarize, this is the same virus. It's an alpha viridae that spreads Zika and dengue. It's spread by Aedes aegypti and albopictus. It's a day and night breeding mosquito. Typical incubation period, as what sir also said, is about 3 to 7 days. The pathognomic signs is fever, headache, bilateral symmetrical, distal more than proximal joint pains, and early morning stiffness, similar to what you get in rheumatoid arthritis. You get a maculopapular rash, again, as per the example that sir gave us, in 3 days post fever. 7 to 10 days after the fever, after 7 to 10 days, the fever usually disappears. And that's the time where you can get CNS complications and renal complications. The diagnostic tests could be done by a RT-PCR between first day and the 7th day of fever, the sensitivity of which is almost 100% and the specificity about 98%. After 8 days, you get the ELISA or the immunofluorescence assay that's positive, and the IgM comes positive after 8 days. I think this is important when we ask for these tests. Of course, as sir said, the differential diagnosis includes seronegative arthritis, reactive arthritis, SLE, etc. Thank you, sir, for those lovely, lovely teaching points. Next slide, please, Zara.
May I make a point here, please?
Yes,
may I make a
yes,
point?
sir. Of course, sir.
Yeah. The thing is that the bad sequelae is the persistence of this joint pains. The persistence of joint pains, which may last not for months, but sometimes for years. And the clinical picture is really of a seronegative rheumatoid disease, chiefly involving the small joints of the hand and also involving the large joints. And the problem is, why is this so? So a lot of work has been done on that. Is it that the virus still persists there? There's a feeling that the nucleic acid of the virus persists, but most people feel that it causes an immunological response in these joints. And that's the reason why you get a picture which is almost indistinguishable from rheumatoid disease. And I can tell you one thing, in a few patients that I've seen who've been like this for a long time, resembling rheumatoid disease, having no relief. Mind you, they are always seronegative. You will never find such a patient being positive for an RA test or an anti-CCP test. But they are helped if you use corticosteroids in these patients. You give a dose which relieves them and bring them down to a minimum possible dose. In fact, it's impossible to distinguish a seronegative rheumatoid from long-standing joint pains produced by chikungunya.
Very good. So as sir said, that hydration, supportive therapy, and sometimes steroids is also required. We'll get to the next slide, please, Sarah. Next set. So this is case number 2 for everyone. It's a 38-year-old man with impaired glucose tolerance, been on metformin 500 milligram twice a day since a year. He's a security guard in a housing society. And, you know, as usual, most societies have maintenance work going on. So is this society. There's a lot of waterlogging at the work site and mosquito breeding. I know everyone's got that diagnosis in their mind. Came with a sudden onset of fever with chills and rigors, 104 degrees Fahrenheit, slight dry cough, 1 vomit. Vomitus was the previous meal. Complained of severe headache, again retroorbital in nature, mild body ache, complained of burning micturition, but not in increased frequency. So, you know, there could be multiple differential diagnoses here. Next slide, Sarah. On examination, he was conscious oriented, vitals were stable, pulse was of course 110. There was no hepatosplenomegaly. There was a mild tenderness in the epigastric area. Cardiovascular, respiratory, and neurological examination was all clear, except for a mildly muddy sclera. He was not an alcoholic. The workup showed a WBC of 3,900, neutrophils of 50%, monocytes of 10%, platelets 53,000. The fasting sugar was 180 with a glycosylator of 7.2. The malaria smear and antigen came positive for Plasmodium vivax malaria. The urine routine, however, remember he complained of burning micturition, showed 20 to 30 pus cells. So was this a dual infection? Urine was sent for culture and the results showed no growth. On further inquiry and better examination, the answer of the urine pus cells came alive. The patient had a rash in the penile and scrotal area, and examination revealed a fungal balanoposthitis. Next slide. So that diagnosis was clear. He was put on antimalarials, local antifungal treatment, optimal diabetic management. Personal hygiene was, of course, reinforced. BMC was informed and appropriate vector control measurements were put in place. The diagnostic clues are several, and the diagnosis is Plasmodium vivax malaria. So your comments on this patient. Unmute, sir. You'll have to unmute.
I think this is a pretty straightforward case, isn't it? Here you have a chap with fever, chills. As usual, you have the usual symptoms which are often seen in a viral infection, but can very well be seen in protozoal infections, particularly malaria. And you did an examination for malarial parasites, and it was positive, and fortunately, it was vivax. Now, the absence of a liver and spleen is possible because you caught it pretty early. Otherwise, liver and spleen are very often enlarged quite frequently in a vivax infection. In fact, much more frequently for the same period of time when you consider a falciparum infection. And here, if I may point out, is a major danger. The major danger in Plasmodium vivax infection, besides the fact that you could get repeated episodes in these people, giving rise to long-standing anemia, long-standing bouts of fever. The major problem that you might get is a ruptured spleen. I've just seen this once in my registrar days, where and you don't see Plasmodium vivax so commonly these days. But in those days, that equally common with falciparum, you could get a ruptured spleen even without much ado, even without much trauma. And this is one of the major complications that you can see, plus the fact that you can get repeated episodes lasting sometimes for years, and thereby producing a fair amount of debility and fair amount of poor nourishment and fair amount of being unable to work and carry on a normal existence.
Absolutely. So any particular points on the, the way we should treat this patient? Of course, with antimalarials, but I think we must also take care of prophylaxis and relapse, as you correctly said.
Yes, of course. You usually combined a combined treatment with your artemisinin derivatives, with usually lumefantrine, so that you give a pretty wide cover not only to this particular parasite but also to falciparum. The combined treatment today is the treatment of choice. because the simple reasons are the artemisinin derivatives can take care of the gametocytes, and that's extremely important. So that, you know, the sexual development of this in a mosquito is not there. But the thing is that you have, if you want to take away the merozytes within the liver, the erythrocytic forms, you need to give them primaquine. Primaquine is a drug which is very often used, and there are people who cannot tolerate primaquine, particularly those who are G6PD deficient. And it is felt that instead of giving the usual dose spread over 2 weeks, you give the dose once in 6 to 8 weeks. And these people, even if they are G6PD deficient, may tolerate it much better. That's the main problem here. But remember that even after giving them primaquine to take care of the exoerythrocytic dose, if the number of merozytes that are present in the liver are marked, not all of them die. So that it's not uncommon for recurrences to occur sometimes over a period of years.
Perfect. We also have a question from someone, and I think we should take it at this point. What about patients or travelers who are coming into endemic areas? So I think people who are coming into endemic areas should be adequately given prophylaxis, especially people coming from the West where malaria is completely uncommon. So we need to attack the malaria. So we can use doxycycline. Suppose someone has to come on an urgent basis. Doxycycline can be begun 1 day before he starts traveling. Needs to be taken every day at a dose of 100 milligrams. And the unfortunate part is needs to be continued for 4 weeks after it goes, because it acts on the erythrocytic cycle. You have Atacocon and Proguanil available in the West, not available in India, 250, 100 milligram. Again, you can start it, 1 day before you come, but you need to continue it for 7 days. So that's a good prophylactic drug. We have Mefloquine, which can be given 250 milligram weekly. Again, start 2 to 3 weeks before, like chloroquine, and continue up to 4 weeks after you leave the endemic area. So I think these are the common drugs that we can use. So anything specific in this?
No, I think that's about it. But as I said, you combine treatment with artesunate plus plus lunafentan for the simple reason. Yes, I think it's extremely important to remember there have been number of cases where the malarial parasite is getting resistant to the artemisinin group of drugs, particularly in Southeast Asia, particularly in Thailand, where there have been increasing reports of even falciparum parasites being resistant to that. And it is this reason that use a combination therapy these days and don't use the drug alone.
Excellent. So I think your points are very valid, because we only have this artesunate group of drugs available and we don't have anything in future. So you must combine them. If you're in hospital, something like doxycycline, clindamycin, or chloroquine, and as Sir said, on the OPD basis with lumefantrine. Next, go on the next case, please. Sarah, next case. Okay, so case number 3, 40-year-old senior executive in an MNC presented with a history of fever since 4 days, severe fatigue lasting for 8 to 10 days, most patients self-treated with paracetamol, dry cough, dull frontal headache with a severe malaise. She said it was just unlike her to feel so low. Her energy levels had suddenly dipped in the last few days and was unable to focus on the work, not because of any CNS complaints, but just because of malaise and fatigue. In the previous 2 days, the fever was up to 103 degrees, accompanied with fever and chills and rigors. She's been working late hours and has been eating in the office, eating out, ordering Swiggy and Scootsy, had a few watery loose motions. She also had a few red spots. She was a fair, pretty young lady. That's why you could see those red spots in the abdomen since a day, which has been attributed to bed bugs, according to her. Next slide. She was given, she's on 50 micrograms of Thyronorm, was investigated for rheumatoid arthritis 3 months prior and was found to be positive, but was inactive, so it required no treatment. On examination, the tongue was coated, white, furry, branchable truncal maculopapules, few and scattered. You literally had to search for them. Mild tenderness in the right hypochondrium, Spleen and liver at this stage were not palpable. Conjunctival insufflation was present in both eyes with a minimal discharge. She also had few red spots on the abdomen since a day, which she attributed to bed bugs, as I told you in the previous history. The blood pressure was okay. Pulse was 74, next slide, having a temperature of 100 degrees when she had come into the clinic. Next slide. So woke up, WBC was 6,600, neutrophils 68. Here, the eosinophils was 0. Platelets were 298,000. MP was negative. SGPT was 32. Urine was normal. You see some bug crawling on the right side. For those people who are viewing, you can identify the bug. Blood culture clearly grew Salmonella Paratyphi A, which was sensitive to cefixime and azithromycin. So the diagnostic clues that we get was a young person eating out, the kind of fever, the pattern of fever, rose spots on the right, and right hypochondrium tenderness. So comments on this case. Unmute, sir. You'll have to unmute. Yeah.
Again, a fairly typical case where you have a fever for a few days and you have a furred tongue, and you've forgotten one thing. I think what you said was she had a watery diarrhea to start off with. Am I right?
Yes,
That I think is a very important clue, because it starts, as you know, with an infection within the gut. I think it's important to know how this infection comes about. It infects the gut and settles down in the Peyer's patches, but that's not it. From there, it goes via lymphatics to the glands draining the gut. And from the glands draining the gut, it gets into the bloodstream. And then from the bloodstream, again goes down to the gut into the Peyer's patches. And that's where it can produce a problem. Now, ordinarily, paratyphoid A is not as bad as plain typhoid fever. But this is one paratyphoid A, which sometimes can be pretty severe and can resemble typhoid fever to a very great extent. So I think the diagnosis is quite great, quite definite. I think the history of diarrhea preceding fever for a length of time is the most important clue here. You found red spots in the abdomen. Do you think those were rose spots?
That's what I've been told on the examination. Those were rose spots. Very uncommon to see in Indians, especially because of a complexion.
Yeah, I think the rose spots are very uncommon on the abdomen. Rose spots are far more common on the chest. So if you see anything in the abdomen which resembles rose spots, think twice. But the rose spot, as you rightly said, it's on a fair skin that you generally make out rose spots. And it is almost certainly not as frequently here as it is seen in the West, maybe because of the pigmentation of the skin. You can't make it out very clear. But it must be remembered. Remember, the thing that I said was, it's not paratyphoid B, but paratyphoid A is one infection which does not end often in 8 or 10 days unless you diagnosed it and treated it properly. They may go on with fever for a long time and may resemble sometimes typhoid fever.
Yes. So, sir, some questions are for Salmonella group of infections. What is the correct timing of which test? Because people ask for Vidal and stuff like that right on day one.
No, that's rubbish. You can't have a Vidal positive in such a short time. And Vidal is certainly not a very good, not a very specific test for the diagnosis of typhoid. To be really positive, you need a Vidal after 8 days. That's the time when you get antibodies. And there even you can say that it's likely to be positive. It's well over 100 to 1 in 200 or close to 1 in 250. And to be sure, you need a 3 to 4-fold rise in this antibody titer after some time, say after a couple of weeks. Then you can be sure that yes, there is a significant rise in titer. And therefore, I'm quite sure that this was typhoid or this was paratyphoid, as the case may be. It's wrong, for example, to just rely on the Vidal. It's a test which used to be pretty popular, but nobody used to ask it in my day within the first 2 or 3 days. It is always asked after 8 days.
Sure. I think for everyone who's listening, a very simple mnemonic to remember when you ask for tests for a salmonella group of infection is to remember BASU, B-A-S-U. First week is blood culture. Second week is agglutination, so it's the Vidal. Third week is stool culture. And the fourth week is urine culture. It's important to ask for a blood culture as early as possible. The best pointer for getting salmonella is to do a bone marrow, which is impossible. It has almost a yield of 90%. So BASU is the way to go. As Sir said, after 7 days or 8 days is the correct time. O is more specific than H. H is more sensitive. In endemic areas where there's water contamination, again, as Dr. Udwarya sir has said, 1:80, 1:120 could be just normal. So rising titers is most important. Some more questions. We have some questions from Dr. Pragnesh Vajrajani from Ahmedabad. He says, is it safe to use any other antipyretic apart from paracetamol in patients of fever? So would you want to take that?
I see no reason why you should use anything else other than paracetamol, for the simple reason that the non-steroidal anti-inflammatory drugs, which can also bring down fever, have an inherent risk, have far more side effects. Whereas if you give paracetamol in reasonable doses and for a shorter period of time, you will have brought down the fever. So there's no reason to really go in for more special drugs for this. I don't think you should.
Absolutely, safest. Pattern of fever, is it still relevant in the current scenarios? So I think he wants us to speak about types of fever, maybe something like continuous fever, intermittent, remittent, relapsing. So do you want to speak something on that?
Yes, you can have continuous fever. Continuous fever occurs in many conditions. Like, for example, even in falciparum malaria, you get continuous fever. You can get fever which is on alternate days or every third day, as in forms of malaria, Plasmodium vivax and Plasmodium malaria. You can get remittent fever. For example, the fever comes, then goes away for a length of time, then comes back again. The classic, of course, is the Epstein fever, where you find that the patient has been afebrile after a bout of fever, and the fever comes back. The interesting thing about Epstein fever is this, that during the period of remission, the physical findings that you have had at that time may also remit, and therefore may lull you into a feeling that things are getting well. And the amazing thing is, when the fever comes back, these physical signs come back. For example, lymph glands, which are clearly palpable, disappear during the period of remission and come back again during the period of fever. You have relapsing fever, as you have, for example, in rat bite and spirochetal infections also. So you have these various types of fever, but the most important kind of fever that one finds it difficult to deal with and requires proper examination, clinical first, and then investigation, is pyrexias, which last continuously for a length of time.
Excellent, sir. So I think Sir has told us that you get continuous fever, a fever that does not come back to baseline. You have intermittent that touches once at least in a day to baseline, remittent where the fluctuation is more than 2 degrees, and of course the cyclical fevers, as Sir said, about Epstein, relapsing fever, and of course hectic, which is continuous fever and high grade, specifically seen in sepsis. So another question is, how do you approach a patient of fever on day 1 with no other signs and symptoms?
Nothing. You just give him paracetamol and see what turns up. You shouldn't start an antibiotic, that is for sure, unless you have classical signs. For example, you have a patient with acute pain in the throat, you look at the throat, and the throat is seriously and severely inflamed, and you think that this could be a streptococcal tonsillitis. But be careful. If you have a patient like that with lymph glands present, I would avoid ampicillin, because the important differential diagnosis of a sore throat with lymph glands, particularly if the lymph glands are just not localized to the submandibular area, is infectious mononucleosis. It's not at all uncommon. It's fairly common. And if you give ampicillin, you're going to do harm. So if at all you're tempted that this is running high fever, his throat is very bad, very sore, markedly inflamed, he's got a leukocytosis, you could give him an antibiotic but avoid ampicillin. But otherwise, if you find nothing else, give nothing.
Tips for maintaining hydration in the geriatric population during episodes of fever at home, sir. That's the last question from Dr. Rajesh.
What is it? What's the question?
Tips for maintaining hydration and importance of maintaining hydration for geriatric febrile patients.
It's very important, obviously. It's extremely important. In fact, you should always make sure that they have a reasonable fluid intake. It's quite possible that you try and feed them orally, but many of them cannot tolerate oral feeds. Many of them vomit. Some of them may be having a diarrhea. So when a patient particularly is febrile, an elderly patient is febrile, it would be wise to give him IV fluids and make sure that his total fluid intake is 2 liters. Of course, watching the lungs and making sure that you have examined the heart to make sure that there is no evidence of heart failure to start off with. But hydration is extremely important.
Yes, SO says, when you have fever, every degree rise of fever, you have an insensible loss about 1 to 1.5 ml per kilogram. So you must make sure that these elderly people are hydrated adequately, not overhydrated clinically, and closely monitoring them. Thank you, Dr. Jawar, for those lovely slides. And thank you, Dr. Pragnesh, for your questions. I will send the next set of slides to Dr. Jawar. Please take over. Case number 4. Unmute.
Thank you, Prateet. And it's been a pleasure to listen to you. It's an honor to be here sharing the same screen with Sir. I'll start with this case of a 49-year-old lady who works as a gourmet chef and does a lot of food tasting at her kitchens. She came with complaints of severe fatigue, malaise, and mild myalgia. She had a severe sore throat, which she attributed to a chronic GERD, gastroesophageal reflux disease. And she said that she had been tasting some spices recently, which were giving her a sore throat. She had a low-grade fever, 99 to 100, off and on since the last 8 to 10 days, and self-medicated with paracetamol and ibuprofen, feeling better for a short while after taking the medication. Occasional nausea and a significant loss of appetite with aversion to food. Next slide. Sarah, the next slide. On examination, she had a temperature of 100.5 Fahrenheit. She had a granular pharyngitis, severe, with minimal postnasal drip and congested fauces and uvula. A mild tonsillar enlargement, no discharge. She had cervical lymph nodes bilaterally and a thyroid nodule palpable on the right side. There was no hepatosplenomegaly, and investigations advice was a sonography of the neck with multiple thyroid nodules and bilateral cervical lymph nodes. Next slide. This was the investigations done. There was a blood count which showed 10,340 total count, neutrophils 36, lympho 54, monocytes were 9, CRP was raised to 13, the transaminases showed mild elevations, the LDH was 508, which was extremely high, platelets 260,000, CRP of course higher, and the prothrombin time was mildly elevated. Procalcitonin was 0.277. The picture in the slide shows a sign which was only elicited as a retrospect, but I've kept this picture here just to tell us that this sign was there in this patient who missed it, telling us in the first instance, because she came almost 8 to 10 days later. Next slide, please, Sarah. The workup was for Epstein-Barr virus. The DNA detection by PCR was not detected in the first instance. The thyroid function tests were normal, euthyroid levels, and an infectious mononucleosis panel, which Sir just mentioned a little while ago. The EB virus, viral capsid antigen, IgM was positive, IgG was positive. So this was a recent infection. The urea was positive. The EBV early antigen was positive, and the NA was negative. The NA usually turns positive after a few weeks. The liver enzymes kept rising for the next 3 to 4 weeks and returned back to normal over the next 5 months. Next slide. Sarah, next slide.
No, we've got it.
Yeah. So the differential diagnosis thought about at that point was an anectric viral hepatitis, thyroiditis, or a HHV6 anti-infection, the herpes virus group, a streptococcal pharyngitis. In retrospect, the patient mentioned that she had noticed swelling of her upper eyelids, which her husband had pointed out in the first few days of her fever, but she had attributed it to lack of sleep and did not think it worth mentioning in her history. This was the typical Hoagland's sign, which was shown in the previous picture, of Epstein-Barr virus, which is present only in the first few days of fever and never later. And the last history that elicited retrospectively was she had recently started sharing hookah pipes with friends. The diagnosis was, of course, the next slide, the Epstein-Barr virus infection. The diagnostic clues were uniformly erythematous posterior pharynx, cervical lymphadenopathy, fatigue and malaise, profound and incommensurate with the fever. Your comments,
So
please.
can you kiss about this? Can you kiss these slides and speak something about this disease?
Yes, sir. You want me to?
Yes, please, sir.
Yeah, I
A
think
little louder, sir. A little
it's
louder.
not
For
at all an uncommon disease in clinical practice. I think that one of the clues is that when you have a patient who has fever and who gives a history of a sore throat, and when you examine the patient and you find lymph glands which are in the posterior cervical train well below what normally lymphatic drainage of the throat and tonsils is, you must always keep that in mind. Also, when you have a patient with tonsillitis, with a grayish membrane, do not always take it as a streptococcal tonsillitis. Again, think of Epstein-Barr. And again, here you will find lymph glands which are well away from the site where the tonsils are being drained. That's the first thing. But the important point is, sometimes what happens is that the patient forgets the sore throat and he comes with a fever. It's not always that the fever naturally disappears. There are some patients where the fever lasts for a fairly long time. I'll tell you that later. And in these people, the fever is, the throat is forgotten. And all you feel are these lymph glands. And I have many patients come to me saying that I have been advised a lymph biopsy for tuberculosis.
It's typical.
It's very uncommon to have tuberculosis, discrete glands on both sides. It can happen, but it is rather uncommon. And if you go back to the history, they might give you a history of a sore throat. Also, by this time, if it's an EB virus, usually you should be having a palpable spleen, and you should be having an increase in the liver enzymes. So you should look at that as well. So these are the two important clues that you have to remember that this might be an Epstein. The odd thing in your patient was that he had a WBC count of over 10,000. Normally, these people have a leukopenia, except when they have secondary infection in the throat. So that's one important point. And also, from the beginning, like all viral infections again, the liver enzymes are invariably raised. So if you've done the liver enzymes at that time, you would have almost certainly found that the liver enzymes were raised. Now, worth remembering that the presentation can be bad in some cases. For example, in some cases, the fever takes a continuous form and it is often treated for typhoid. In other patients, the fever is continuous, the glands have almost gone completely, they are nondescript. So one of the things that you should always think of in a
Prateek sir's mic is muted, I think.
Yes. There's a Wi-Fi issue there. I think Sir wanted to say that you need to be, for such patients, by the time he gets his audio on, you need to look for, do a good physical examination. Epstein-Barr virus plays on the T and B cells, so it's a risk factor for developing lymphomas, malignancies, and especially oropharyngeal malignancies also. So it's not an uncommon disease. EBV should be, and actually typically what Dr. Jawar also showed, the WBCs may start rising later, but the lymphocytes and monocytes go disproportionately higher. That should be the clue to say that this is a viral infection. And as what Dr. Udvarya said, it's not like a salmonella. LDH is another excellent surrogate marker to show that this could be an Epstein-Barr virus, which our patient had. The test to do for Epstein-Barr virus is a PCR test. A PCR test can be done in the first 7 to 10 days. The antibody tests are usually positive after 7 to 10 days. They're never positive usually in the first week. Sometimes you need to repeat the EBV antibody tests up to 3 weeks to get a diagnosis of certain for EBV infection. Any questions there, or I can go to the next slide? Should we wait for Sir? Should I call him up and find out what's happening? Let me call him up and find out. Any questions there, or I can wait for Sir?
There's just a little bit of slight information there. Was Epstein-Barr virus was named after Michael Anthony Epstein and Yuan Barr. Michael Anthony Epstein just celebrated his 100th birthday last month, and he's still very much there and active.
I can't, I think he's not answering the landline number. One sec. Hello. I'm just speaking to him. Give me a moment, please.
He's connected.
Yeah. Okay. Can I?
Okay, I've got it sorted. Yes, yes, yes.
Can you hear me?
Yes, sir, but you'll have to just get your video on, please.
Yeah, I'm just doing that. Yeah.
Yes.
Yeah. I was saying, you know, you can get a typhoid-like fever. Sometimes you get hemolysis, so you have a picture of a hemolytic anemia. Sometimes you have nephritic complications, but most important of all, sometimes you get neurological complications, again, like so many viruses. And here again, you can get a Guillain-Barré syndrome. You can get a meningoencephalomyelitis. In other words, as you see with all viruses, when the infection is usual, the average infection, it goes away. But when it is bad, it is real bad. And that holds also with the Epstein-Barr. There's two important things we should know about this. There is a rare form of an X-linked infection occurring in young males due to a genetic change which exposes them to the proliferation of cytotoxic cells and natural killer cells which proliferate in abundance and produce the picture of marked damage to all organ tissues, exactly like a hemophagocytic syndrome. And rarely, and this I didn't know till some time ago when I had a patient, you know, these patients have a chronic infection. I've never known this. I have never seen it, but it is worth remembering. They have a chronic infection in the sense that they have fever for a long time, goes away, fever comes back again, hepatosplenomegaly, lymph glands present, and they go on and on and on like that. And sometimes again end up, as I said, with the hemophagocytic syndrome. So these are the important points to remember. The first kind of patient that I told you is male, X-linked, genetic change in a particular gene which controls the cytotoxic cells, nuclear killer cells, and the T cells. But we all know, those of us who have worked in the ICU, that sometimes one of the most common causes of a hemophagocytic syndrome is a prior infection with GB virus, and that can occur either in a male or in a female.
So what about the risk of malignancies? I was just telling them when we were getting repaired with Epstein-Barr viral infection.
Sorry?
Malignancies with EBV, reactivation of EBV later in adult.
You see, in two things, one never knows why when it affects children, how it has come there. No one knows how. When it affects adolescents and young adults, it's generally related to kissing. As you know, a carrier can have a marked replication of the virus in the salivary glands and in the mouth, and therefore it's very well known. But I can't understand what must have happened to have that in children. By and large, they are asymptomatic, but sometimes they will be mildly symptomatic. A reactivation in later years, once you have an EB virus, you are a carrier for EB virus. If you have a reactivation of this gland, you may have nasty diseases. You have, for example, you have lymphomas, you have a B-cell lymphomas, you have a nasopharyngeal carcinoma, which is also very well known, salivary gland tumors, which are also very well known, and some forms of gastric carcinomas, also which are very well known. And as I said, you could possibly get hemophagocytic syndrome as a result of a reactivation in a patient.
Yes, and as Sir also said, there's no definitive treatment; it's just supportive treatment.
Nothing,
and in the in the previous slide, Sir was saying that if you use penicillin group of drugs, you may get a rash. So that could give you an indirect clue to say this could be Epstein-Barr viral infection. Can we go to the next slide? So can we go to the next slide, Sarah? So I'll come back to another case, a 30-year-old male stockbroker who has been, his office is at the stock market, and he's got lovely food down with all the pani puris and bhel puris below his building. 5 days history of acute onset of fever, 104 degrees, severe chills and rigors twice in a day. Pain in the abdomen, initially mild heartburn because of eating all the pani puri, epigastric area, dull aching in the epigastric, and then going to the right hypochondriac area. Complained of recent onset of halitosis, that's bad smell, slight dry hacking cough, and occasionally pain on the right side of the chest whilst coughing. There was no diarrhea preceding this illness or at this moment, and no vomiting. He, of course, complained of loss of weight and appetite. The residential building received tanker water since the last few months, like most offices in Mumbai would, and there were multiple cases of diarrhea in this building. Next slide. Next slide, sir. There was no change in pain or deep breath after 5 days, no pain on the right shoulder, the patient kept leaning on the left side during history of walking or sitting on the chair. He claimed that it made him feel just more comfortable. History of hyperacidity and indigestion precedes most of our Indians, whether it's myocardial infarction or a gastrointestinal infection. On examination, pain and firm pressure in the lower right intercostal space, mild tenderness in the right hypochondrium area, liver and spleen was not palpable. The pulse was 110, pressure was 130, tongue coated, and halitosis present. Next slide. CBC, predominantly polymorphic leukocytosis. Stools were normal. SGPT was mildly elevated. Alkaline phosphatase was slightly raised. An amoebic antibody IgG was asked, which was strongly positive. Sonography certainly confirmed a clinical diagnosis of hypoechoic round to ovoid lesion with well-defined margins, which was seen. And CT furthermore told us that it was a well-defined area with complex fluid enhancing wall and peripheral zone of edema with a wall thickness of 3 to 5 millimeters. and the central cavity showed no septations, probably ruling out something like a hydatid cyst here. Next slide. So the differential diagnosis was malaria, salmonella, pyogenic liver abscess, hepatitis, or hydatid cyst. The diagnosis with the serology and the CT scan was certain that it was a amoebic liver abscess. Patient was treated comfortably with the drugs which we will discuss. The diagnostic clues were clear here: fever, abdominal pain, eating roadside food, residential building, several cases of diarrhea because of tanker water coming into the building, and of course, pain on sitting posture, leaning to the right, investigation confirmed. So your take on amoebic liver abscess, it's far so common in our country.
Am I muted?
Yes, yes.
Yes, it is quite common. There are a couple of few things. Did you do an X-ray of the chest?
Dr. Jawahar, yes, I'm sure the X-ray would have been done. There was probably no right pleural effusion, or the diaphragm was not raised, if that's the question you're asking, sir.
Right. Where exactly was the abscess, and what was its exact situation in the liver?
Jawahar?
Where was
Can you go to the previous slide, Sarah? The previous.
It's interesting because you're seeing a thick-walled abscess. A thick-walled abscess is, makes you feel that the abscess might have been there for some length of time. It's not common to get a thick-walled abscess in how many days fever?
Almost, sir, about 5 days before presentation, but he had this little loose stool before that.
It's possible that this man has had an amoebic abscess for a length of time, before he noticed the pain. And it's a small abscess. What was the size of the abscess? You haven't mentioned that.
No, it was a small abscess. It was not a big abscess.
Small abscess, me? Right.
Yeah.
So no wonder, he had no symptoms for a length of time. He must be having it for quite some time before, you found out. And the odd thing is that it must be close, I'm sure, to the border of the right lobe of the liver for him to get intercostal tenderness, for a small abscess like this. Otherwise, it will not give it. An amoebic abscess, for example, in the center of the liver will give you no physical findings at all. He may just run a pyrexia of unknown origin. In earlier days, mind you, when there were no facilities available, many of these people with pyrexia of unknown origin had to be explored to find out, is there something within the abdomen? And one found sometimes an amoebic abscess. So otherwise, X-ray of the chest is important. It is very often typical, unless it's far away from the diaphragm.
The chest X-ray was normal.
Fine. So I'm not surprised at that, because it was a small abscess and it was not abutting against the diaphragm. So otherwise, your diagnosis is from the antibodies that you found, and your diagnosis is from your imaging, and that proved the point. And I don't think you should think of hydatid, because there were no septations at all. Differential diagnosis, of course, is whether he could have had a pyogenic abscess, but there was no reason to suspect a pyogenic abscess. If a pyogenic abscess, from where? On the other hand, he was a worker. He was taking water which was not quite healthy, and he probably had some amount of amoebic infection for a length of time. Once again, it is uncommon to get simultaneously an amoebic dysentery and an amoebic abscess. It's uncommon.
Yes.
So it's quite possible that he's had an amoebic infection in his bowel for quite some time, and had diarrhea recently, but it's quite possible that he's had amoebic infection for quite some time, and from there he got the flu.
Yes, as Sir says, pyogenic abscesses are usually from the biliary tract, and so they will have pain, fever, or peritonitis. So there'll be preceding, examination findings for pyogenic abscesses. Also, as Sir also says, you don't need to tap these abscesses. You don't need to get the anchovy sauce because they are small, and treatment with metronidazole should be good enough for about 14 days.
There are two
That's right, sir?
Yeah. You need to tap an abscess, even if it is small, if it is in the left lobe, and if it is abutting on the diaphragm, because the danger here is of involvement of the pericardium. You need to tap a left lobe abscess, even if it is not abutting on the diaphragm, when you have a little fluid in the pericardial side. There is a danger again there. And you need to tap an abscess when it is over 7 to 10 centimeters in size. And you need to tap, of course, an abscess which occupies the greater part of the liver. They are horrible. And not only do you need to tap such an abscess, which occupy the whole, because you go on tapping and tapping and tapping, and the same fluid returns. It is these people in which you need to put a drain. There is always some risk of secondary infection when you put in a drain. But a very large abscess, which goes on filling again and again, you might need to put an intercostal drain in these individuals. And it's important to decontaminate, if I may say so, the gut as well after you've treated the amoebic liver abscess. That also is extremely important. Finally, there are cases of amoebic abscesses which are resistant to metronidazole. And I'll never forget a patient we had. He was in bed number 2 in the medical ICU. He was brought in for fever for 3 days. He was brought in. An amoebic abscess of the liver was diagnosed within the first 6 hours. He was treated on metronidazole, full doses, straight away. You won't believe it. We never could control the abscess. We never could control the abscess, and he died of it. And there are case reports where the amoeba, some of them, it's rare. This is the only one I've seen, which could be resistant to metronidazole. And never forget.
Sir, it's also, yes, go ahead, sir. Yes.
And as I said, lung complications are most important. I think everybody knows them. Pleural fluid, presence of atelectasis, a little atelectasis of the low plate atelectasis, particularly just above the diaphragm. These are all pointers to an amoebic liver abscess. And finally, of course, if an amoebic abscess ruptures, it can produce a consolidation in the lower lobe. It can produce a fistula between the liver and the biliary system and the bronchi, literally. And if it ruptures in the pleural space, it can produce a pretty large-sized effusion. One case which I remember again, where a patient presented with an effusion for many days. And it was thought that it was an empyema, which it was. But the etiology was an amoebic infection. So it's a point which is always worth remembering.
So it's also important to tell our colleagues that you do not tap the abscess if it's not liquefied just because of its size. You have to wait for it to liquefy, else you will get nothing. And the color is typically anchovy sauce. Next slide. We'll go to the next case. We'll finish this quickly. So we have a 28-year-old married female referred for fever to me. Fever since 22 days, low grade, maximum going to 100 degrees Fahrenheit, accompanied with fatigue, mild weight loss, occasional grittiness in the throat. There was no other complaints. Past history, she's a nursing mother for 4-month-old, uneventful pregnancy, no other comorbidities. She was thoroughly investigated for diabetes, thyroid during her peripartum period. She just had an antibody positive for thyroid, TPO positive in the first trimester. And then thereafter, her thyroid level functions were always normal and it became negative. She has 2 siblings. One sister also had similar fever after the first baby. Whether was it an incidental or accidental finding, we'll find out. Next slide. On examination, vitals are normal. Systemic examination, including a thorough palpation of the neck and the peripheries, were all normal. WBC was completely normal. ESR was just elevated 82. Thyroid functions were normal. It was just done about 15 days before coming to me. Malaria, someone had done, was negative thrice. Dengue, lepto, 4 blood cultures, Vidal. Someone had also done an ANA double standard DNA, which was negative. A sonography of the abdomen, pelvis. Because she was breastfeeding, someone thought there could be a small abscess, sonography of the breast, X-ray tests were all normal. So what next? When we examined her, these were the findings. Next slide. So this patient gave me a couple of clues. This patient gave me a clue that she had an antibody positive. She had a sibling who had a similar history of fever postpartum, and she had just low-grade fever with no other signs. I asked for a sonography of the neck. It showed a small 1.2 by 1 centimeter nodule in the posterior part of the left thyroid gland. It was small, so therefore it was not palpable. Antithyroid antibodies was strongly positive. Antiperoxidase was 1:1200, and the antithyroglobulin was 1:320. The FT3 at this moment was 8. Please remember, she had done one about a month ago or 40 days ago. FT4 was 26, which was again normal, but again on the higher side. A TSH was less than 0.015. Certainly, this was clearly to me thyroiditis. I asked for a radionuclear iodine thyroid scan. It showed bilateral diffuse, sorry about the diffusers, reduced uptake in both the thyroid gland. And my diagnosis at this moment was painless postpartum thyroiditis. So if you want to just comment on this case and
Yes,
how frequent are thyroid disorders and pregnancy?
I know I would like to comment on this case, otherwise it will be too long. Let me just comment on this case. Here you have a pyrexia of unknown origin, right? And what clue do you have besides this small nodule, which is insignificant and which I don't think you would bother about since you couldn't feel it also, right? And what else, what other clue do you have? You have an extremely important clue. You have an ESR which is close to 100. So if you have an ESR which is close to 100, you can count in the fingers of both hands what it could be. And one of the things that does do is a thyroiditis. And therefore, any pyrexia of unknown origin, which has lasted for a length of time, you are duty bound to do the antithyroid antibodies. And once you do the antithyroid antibodies and they are strongly positive, and you find the TSH rather low, 0.04, you said. You should,
yes, sir, 0.015.
You should do a scan and you should be able to make it out. Now, there is one interesting thing about thyroiditis. Not particularly when a thyroiditis is not roaring, not acute, it's subacute. It is important to remember that the patient may not remember at all a mild discomfort that he or she might have felt 22 days ago. If you have a severe pain in your knee just now, and I ask you, did you have a pain 3 weeks ago? You would say no, because you can't possibly recollect that. So in many of these patients, not the acute ones, which are quite, they'll give you a history, or they'll give you tenderness over the thyroid. But the subacute ones, worth remembering, the reason for not having any pain is it might have been so mild that she didn't recollect it 22 days ago. That's the most important thing.
Yes. So I'd just like to tell you just a minute on thyroiditis. There are several types of thyroiditis. So you have Hashimoto's thyroiditis, where typically you'll get a high TSH. On examination, you'll get a firm nodule or multiple nodules. Please remember that. You have painless postpartum, like our case. You have painless sporadic. I'm sure sir has seen several men also who come with pyrexia of unknown origin, no tenderness, ESR high, antithyroid bodies positive, and an iodine scan confirming thyroiditis. You have a painful subacute variant, this variant which is very less common, but sir just explained, tenderness in the neck and throat area. Of course, you have suppurative, where you have pus typically seen in immunocompromised patients with HIV, and sometimes you can get pneumocystis carinii in this. Drug-induced is very common, amiodarone, interferons, lithium. And then the last one is Riedel's thyroiditis, where you get a hard thyroid mass because of fibrosis, and surgery is, the only treatment. Now, how do you differentiate postpartumly painless thyroiditis versus postpartum Graves' disease, which is also common? It's completely clear. In the iodine scan, you'll have a decreased uptake in the postpartum thyroiditis, and the uptake, there's a surge of thyroid, so the uptake in Graves will be very, very high. In the postpartum thyroiditis, 8 to 10% of the patients return to normal thyroid function by doing nothing in the next 1 year. But unfortunately, 50% of them turn into hypothyroidism in the next 5 to 7 years. It's also important that these patients, if they have another kid or they're pregnant again, it's very likely that they will get a similar attack in the next pregnancy. It's also important that these patients, if they have another kid or okay, can we get the next case? We have Dr. Preeti Shankar from Bangalore, who's going to present the next case. Dr. Shankar, all to you. Sarah, next slide.
Good afternoon, everyone. I thank Mumbai Sea Ward Association and Mumbai Medical Union, FFPI, Dr. Anil and Dr. Janak for this opportunity. I am very privileged to share the screen with Dr. Udvadia, sir. Good afternoon, sir. The courtesy of this case goes to Dr. Subramaniam. It is a case of fever with an unusual presentation. Mr. X, 35 years, presented with high-grade fever with chills of 1 day duration. He was a very active young person, very active in the sports, and the fever was acute onset. There were no associated symptoms, no significant family history or past history. On examination, there was nothing very significant. So paracetamol given and treated symptomatically, and he was asked to come back with a temperature chart after 2 to 3 days. 3 days later, patient came back. The fever continued more in the evening and cyclical fever. At this stage, CBC, ESR, dengue, Vidal test, malarial parasite, urine routine, blood culture, all these tests were done, but everything came normal. So the symptomatic treatment was continued and patient was asked to come back after a few days. Next slide. Sarah, next slide. Yeah. The repeated investigation showed X-ray of the chest, ultrasound, abdomen, all were normal, but Vidal came positive, which was negative earlier. AH and BH was 1 in 160. With this change in thing, the diagnosis or tentative diagnosis of typhoid was made and treated with cefixime and ofloxacin combination. In spite of that, 3 days later, the fever continued, but patient came back with very severe right hip pain. And there was no history of fall or injury. The hip pain was so bad that he was not able to move around easily. He was reassured and continued the same treatment, thinking that it could be a muscular pain. 3 days later returned, fever was still continuing, and the pain worsened to the extent that somebody had to help him to go to the bathroom. Slide 3, please. Now the X-ray of the hip was advised, which was Sarah's slide, previous slide. The X-ray of the hip was normal. MRI of the hip was done, which suggested inflammation. The CT guided biopsy done, and the biopsy material was sent for histopathological examination, which showed granulomatous lesion, and gene expert liquid culture for TB. Gene expert and liquid culture came negative. So the orthopedic opinion was sought. The orthopedician initially just said, this is nothing to do with orthopedic, please go to the rheumatologist. So the patient was not convinced, and even Dr. Subramaniam was not convinced. So he took a second opinion from an orthopedic. Since the TB test, gene expert, everything was negative. The second orthopedician, who was a very senior person, he said, I have seen many cases like this, and it is only tuberculosis of the hip joint, and he started with ATT, CAT, without any further investigations. The patient started the treatment. He was convinced, though the test came negative. He had a discussion with Dr. Subramaniam also, and he agreed to start the treatment. And 4 weeks later, he was much better. 8 weeks, he was still better, able to walk around very comfortably. 6 months later, he completely recovered. He started his sports activities also. Next slide, Sarah. Now, I want a discussion on this case. Was it typhoid in the first place, or was it not typhoid at all? Was it right to treat him as a typhoid? Or is it typhoid and TB? Can we rely on modern investigations totally? Because histopathology, gene expert, culture were all inconclusive. And when everything else fails, is empirical treatment still an option, as was done by the orthopedician?
I'll take that on, ma'am. I think what you did really was, for all practical purposes, the right thing. I just wanted to ask, when you did an MRI, where was the inflammation?
Dr. Subramaniam? Dr. Subramaniam, unmute yourself.
Where was the inflammation? Was it in the synovium? Was it in the joint?
Sir, it was in the synovium.
It is in the synovium. It was therefore a synovitis. Am I right?
Right. Right.
Right. Now, there are only two things. And the point, why I say that you're probably right is because you did a biopsy, you tried to come to a diagnosis, and you found out granulomatous inflammation. And on the basis of that, I think you would be justified in starting anti-TB drugs. Because if it is a it's a granulomatous synovitis, the commonest cause of a granulomatous synovitis is tuberculosis. Would typhoid produce a synovitis? Typhoid usually affects the joint more than anything else. It can affect any joint, but more often than not, the spine. And this is too small a period of time for typhoid to involve the joint. You get a typhoid involvement of the joint, particularly the spine, well after 3 or 4 weeks, after the fever has gone, after the patient is feeling well, then he starts. And as I said, the joints involved are not usually the large joints, it's the spine, it's the axial skeleton. So I don't think, and the Vidal has no significance at all. If you did not find on a biopsy a granulomatous inflammation, then it could have been anything. You know, a plain synovitis, you know, sometimes happens with fever and it may resolve. But once you find granulomatous inflammation, I think you are justified, without opening the joint or going further into the picture, of saying that, what was the ESR? You didn't mention that.
It was 37, sir.
How much?
37.
That's nondescript.
Yeah.
If you had a high ESR, it would have been made more convincing. But a low ESR does not exclude sugar cells. So I think you've done the right thing.
Sir,
And
in this,
listen, ma'am, you know, most of medicine is empirical. You must remember that. Most of medicine, particularly acute medicine, emergency medicine, is empirical. For one thing, it would be unethical to try and prove it. And for another, you can't wait, you know, for all your empiricism to be, you can't wait for proof, randomized trials, etc., in problems which are acutely ill. You need to go by your clinical findings and whatever investigations you have. Take a patient with sepsis, for example. You may say, where is the evidence that the patient has? It's the clinical evidence that he has sepsis. Yes, the cultures are negative. Yes, I know the cultures are negative, but he looks sepsis. But I have thought of conditions which resemble sepsis, and I've excluded them. So I can't help but think that this is sepsis. That's how it is. So it is empirical. And this is an important example, an empirical example, an example where an empirical treatment was absolutely justified.
Also to look for a primary focus of tuberculosis if you had, suppose in the chest more thoroughly or elsewhere, which will also help us clinch the diagnosis.
X-ray chest was normal. Unmute, Subbu, unmute.
No lymph nodes anywhere else in the body, and chest X-ray was normal. But what was really interesting in this case, or unusual in this case, was acute hip pain, which we as a sportsman absolutely normal. Sudden onset of severe disabling hip pain. This is something very unusual, I felt.
Very correct. But you know, as I said, if you had not found granulomatous changes in the, now, you know, you might, the question arises, was he a good pathologist? Was he really seeing granulomatous? Was he imagining granulomas? If that's so, it's a different question. But if otherwise you found a patient like this with an acute hip pain, you would have said that he has a synovitis of undetermined etiology and have left him alone, giving him just anti-inflammatory drugs and seeing how he would have fared. But you've given me a very important clue that on histology, he found granulomas. And if that is correct, that wouldn't happen with an ordinary synovitis.
Sir, with this modern approach of tuberculosis diagnosis and management, we are supposed to clarify whether it is sensitive to first line or resistant to first line, because we may miss if it were to be an MDR case, because we didn't have a tissue diagnosis in this case.
I think it's very unusual to get MDR TB in the joint without having MDR TB anywhere else. For all practical purposes, therefore, I think if you gave the conventional treatment and you showed that he responded to it, it proves that he was not.
Yeah. Yes, sir.
Thank you very much. Sarah, can we go to the next case, please? So we'll just run through this case, and some questions have been asked. Dr. Dholakia has put up this case. So we'll go to the questions. The case is very similar to any acute viral febrile illness: fever, joint pain, muscle pain, rash on the leg. Clinically, nothing on examination. Next slide. So what do you want to know? No, one previous, please. Do you want any more history? Differential diagnosis, as I said, includes malaria, dengue, lepto, just a flu abscess. What is most probable? Which minimum test? We've discussed this in the previous slide. What do you do for a patient who's come with 1 day of fever? Next slide. Treating for the family practitioner. The family practitioners advised the CBC, dengue, smear, and started anti-malarial medication empirically. Next slide, Sarah. So hemoglobin turned out to be 8.2, WBC 4,800, platelets 90,000. Dengue NS1 was positive, MP was negative. The questions asked here are: does he require hospitalization? Patient is not willing for hospitalization because husband is out of town. So the doctor here has given the patient IV glucose saline drips at home, started on augmentin, some vitamin, and given a full diet. After 48 hours, the platelets drop to 81,000. Fever starts coming down. IV is stopped. Oral and lots of fluid is encouraged for the patient. By the 8th day, the platelets drop to 22,000. Should you give this patient, sorry about this, platelet transfusion? Next slide. We will take the questions together, so I'll just read the questions. Next slide. Options. Do you choose cortisone to boost up platelets in a patient with dengue? Do you wait until it comes up? Do you immediately admit? Or do you give those dragon fruits, etc., etc.? Next slide. The family practitioner continued his treatment. The lady, like any natural viral fever, recovered. Was it necessary to ask for IgM and IgG when the NS1 was positive? If yes, which day? Next slide. So, of course, if this has been a secondary dengue, what is the chance of DHF and DSS, and what would be the picture then? Would you do an ELISA to distinguish primary and secondary dengue? So these are some questions about dengue. So if you want to take them.
Yes, certainly not admit the patient. It was not necessary. Certainly not use anything to boost the platelets up. They almost always come back on their own. Would you do an IgM and IgG? Yes, I would always do an IgM and IgG, even though the NS1 was positive. And I would always do, particularly if the patient was seriously ill, I would always do a DO ELISA test to see the IgM and the IgG. If you ask me if it is secondary level, now this is very important. It's uncommon, but I think, it's best to consider dengue on a continuous spectrum of the average case which recovers on itself, the moderately severe case, and the really severe dengue. Recent WHO classification of dengue, I don't know if how many of you all are aware, is simple dengue, dengue with warning signs, and severe. That's rubbish, in my opinion. The Americans are particularly very keen to classify things. There is no reason to classify them. Simple dengue, not so severe dengue, and severe dengue. In the not so severe dengue, this is what the picture is. The picture is the patient looks a little more ill. The purpura might be a little bit more. The platelets have suddenly fallen sharply, and there is perhaps an increase in the purpuric spots and maybe even a slight bleeding from the urethra. You wait, and very often, not very often, quite often, it all regresses. And then it might suddenly graduate into the severe dengue. But severe dengue can occur without warning signs. That's the most important thing. You may have no warning signs at all. And the classic features of severe dengue, warning that I personally feel, is any individual who, besides the purpura and the fallen platelets, has the presence of increasing fluid within the body. Little edema of the feet is not uncommon, even in ordinary dengue. But if you find, for example, crackles in the lung which did not exist before, that, in my opinion, is a warning sign. And the classic features of what you call severe dengue are hemorrhagic manifestations, increased edema because of transudation of fluids all over. Now, the transudation of fluids is related to separation of the endothelial cells, not destruction of endothelial cells. And the hemorrhagic dengue is because of destruction of endothelial cells, because of a vasculitis, because of a coagulopathy, often associated with a fibrinolysis. That is indeed a disaster. This may occur by itself, mind you, and you may be fortunate to manage him, and he might recover. But more often than not, severe hemorrhagic dengue is associated with dengue shock. And that, of course, is a very good, so you have in a secondary hemorrhagic manifestations, manifestations of edema, and most important of all, evidence of shock, and finally, organ failure. In one single individual, you may have various combinations of all these 4 major factors, any one of which may predominate. In one, the hemorrhage predominates. In the other, transudation of fluid and shock predominates. In third, uncommonly, very uncommonly, it's disturbance of organ function. And that can be any organ function. As I told you, any viral infection is usually not bad, but when it's bad, it is really very, very bad. And I remember seeing 2 patients straight with a meningoencephalitis, not my patients. One I remember was Dr. Balsekar's patient, adolescent. Within a few days, he came with unconscious meningoencephalitis. Another, I was referred in another hospital, an elderly man who sooner or later lapsed into meningoencephalitis. So the other thing to remember is a dengue with secondary infection is always dangerous. So if you have a dengue and you suddenly find the white blood cell count rising, be suspicious. Because these patients, have often a very stormy course and their prognosis generally is bad. So remember, you have these 4 major things in severe dengue: hemorrhagic manifestations, transudations of fluid, shock. They may be in different proportions. They may be all be present to the same degree. One may be more, one may be less in another. And finally, you have organ function. All right?
Thank you so much, sir. I think for our family practitioners, it's important when you repeat a CBC to make sure that the hemoglobin does not rise. Every rise in hematocrit and hemoglobin means the patient is not getting adequately hydrated and could turn into a more severe form of dengue. Another test that we can do is called the immature platelet fraction. It's not a very reliable test, but it can guide us if you have drastic falls in platelets and the immature platelet fraction is more than 7 and 8 and 9%, most likely this patient will recover in terms of the thrombocytopenia. Thank you very much, sir. I think we'll go to the next slide. We'll come to the pandemic era. I have Dr. Rushin Mehta, who's going to be talking about the 2019-20 pandemic.
Good afternoon, everyone. Thank you for this opportunity. Thank you, Dr. Prateek Samdani, sir, and Dr. Udwadia, sir, for me to give this opportunity to talk. So given in the background of today and the case of this year, we would say this is a gentleman. I would like to discuss two cases. This was a gentleman who was an 82-year-old who was a hypertensive male. He was physically active with his regular walks and swimming. He came to me with a history of mild fever and chills, and he had sweating of 3 episodes over 4 days. The fever always hit the baseline, but always went up, but never went beyond 100 to 100.5 degrees Fahrenheit. He had a headache and he had a lot of body ache, but he had no joint pains or any body ache, but he only had a mild headache. His main complaint actually was when he called me was his hypotension. He had a blood pressure machine at home and his blood pressure, which went down to 90/50. And he had a lot of tachycardia on his pulse oximeter, which he had at home, which was showing around 120 to 150 per minute. He also complained of breathlessness. He was slightly orthopnic. He could not lie down flat when he was trying to sleep at night. And his saturations on his oxygen, on his pulse oximeter showed a 90 to 92% on room air throughout the day and throughout the night as well. Sarah, next slide. So immediately he was referred to the casualty of the hospital. Unfortunately, due to the current pandemic, he was referred from one to the other. Eventually, he was able to get an ECG done and a 2D echo by a senior cardiologist. And the ECG showed that he had atrial fibrillation with a fast ventricular rate. And his 2D echo showed a left ventricular mild hypokinesia with an ejection fraction of 40% with tachycardia. His previous echo was done just a year and a half ago by another cardiologist, and that time there was no such hypokinesia and his ejection fraction was normal. His chest X-ray showed very mild congestion on curly B lines with prominent, but not very significant. And of course, at this given side, he was given admission advice as a COVID suspect. Next slide. Unfortunately for him, it took us almost 2 days to get a bed in this current scenario. But fortunately for him, his COVID swab came negative. He had no history of exposure, mind you. He was only going down to his garden for walks in his building compound. And all the materials which came home for food were always taken care by his daughter. And he never touched anything per se. His malaria came positive on the peripheral smear, showed Vivax malaria. He did not have any hematological abnormalities as CBC. Otherwise, his platelets were maintained normal. He was treated with anti-failure medication and anti-malarials. He's recovering well in the hospital, and his ejection fraction has normalized to 55%, and his hypokinesia has reduced. His atrial fibrillation is under control with the medication given, and he should be discharged within 2 days. Next slide. So the questions were The questions were in this regarding current scenario, patient being hypotensive, being breathless with oxygen saturation low, just having fever with chills. How do we tackle and how do we go ahead when it was a simple malaria which could have been treated home and it would not have got affected with this current scenario?
I think you have a clinical picture where the patient had atrial fibrillation. Am I right? With a fast rate.
Yes, sir.
It would explain, most of the symptoms. Did he have fever?
Yes, sir. He had mild fever, 99 to 100, with chills, with very mild headache.
I mean, in these days, if you want, you may go ahead and get it done. But in absence, of before the COVID pandemic, I mean, you would just treat it as a patient, with congestive heart failure related to atrial fibrillation and a very fast ventricular rate, particularly an elderly individual where this is extremely common.
Right.
Where, everyone says that you look at COVID all the time. So, well, you did it and you didn't find it. So he's fortunate and he's been treated well. That's all.
The only thing here was, I think his saturations were too low for his relatively mild congestive failure. 90-92 on room air for a mild congestive failure probably made him think that it could be COVID.
Don't forget that he was a very elderly man, and elderly people do not have high percentage saturations. They would normally have a 94 or 95, and with congestive heart failure, I don't think 92 was particularly bad at all.
Thank you, sir. So the question was only at this given scenario of COVID in the background. He lost 2 days in admission due to the COVID. So, of course, we could have done the blood test at home, and they could not find someone to come home to do the blood test due to their logistical issues. The question was, can malaria actually show a picture like this, or these are absolutely two different aspects, and they just came in the same patient at the same time?
He must be having a malarial infection for quite some time, I think.
Okay.
Because you need not necessarily have malaria manifest, but perhaps within the next 5. Did you treat him for malaria?
Yes, sir. We treated him, and he has responded well.
But he might have manifested the usual clinical symptoms of malaria within a short time if you had not treated him.
Okay.
Also, you have two pathologies here: malaria and the cardiac problem. And don't forget, atrial fibrillation with a fast ventricular rate can very easily bring down your saturation in LLE.
Yes, sir. Yes,
and
sir.
hypotension.
And hypertension. So, but can COVID show a picture like this as well if the malaria was negative?
COVID, it has been shown, can affect all organ systems. It has been known to also affect the heart, but it primarily affects the lung. And if the lung remains unaffected and the heart is so affected, I would, anything can happen in medicine, but my explanation would be that this is hypertension, ischemic heart disease, atrial fibrillation with a fast ventricular rate with cardiac failure.
Thank you.
Coexisting malaria.
If you want to really be sure, Rushan, one can do a CT chest, and that would give you more clue if there was just failure or COVID along with it.
Thank you.
You want to take the next one?
Slide. Next slide. So there's a young athletic male who's 42 years old. He is hypertensive on olmesartan daily, well controlled. He had fever for 6 days, high grade, with only temporary relief on paracetamol. He had excessive fatigue and headache, persistent, without any joint pains. He had no gastroenteritis changes. He had lost his appetite. He had a coated white tongue. He had lost his taste in the mouth, and he had no cough or breathlessness. But again, due to the current scenario, he had a pulse oximeter at home, and that triggered us to check it, and it showed a pulse oxygen saturation of 94 to 95%. He did not give me, so his oxygen saturation was 94 to 95%. His only history of exposure was that he goes for regular walks in the morning around his building. And one day he had met a migrant worker he was wearing a mask, and he was just talking to him at a social distance. It's the only history he gave me. Sarah, next slide. His reports, his X-ray was immediately done on the 6th day. And we had also done a COVID swab test. The artificial intelligence at the center picked up that on the right side of the lung, there was congestion and a COVID suspect observation. On the left lung was markedly normal. His blood test showed that his ESR was 21, his hemoglobin was 13.3, his WBC was 6,400 with a neutrophil of 47 and lymphocytes of 40. His CRP was mildly elevated at 3.2, but his LDH was normal at 242. His malaria, parasite, and dengue reports had come negative. Sarah, next slide. He was immediately admitted next day when he was being examined. He was admitted to the hospital because in the night his saturation dropped to 88% and he got a bit breathless. The COVID test came negative, but he was kept in the hospital for observation. The following day, the CT scan was done, which showed ground glass attenuation on the right lower lobe and lingula. On the 3rd day after admission, again his COVID swab was repeated, which then eventually came positive. So that was the 9th day of his fever. He was tested again and it came positive. He was then treated with the steroids, hydroxychloroquine and azithromycin, and he is completely recovered and come back home, and he's quite fine now.
I'd really like to comment on this particular case.
Please, sir.
I'd like to know why you gave the Solumedrol and the HCQ and the azithromycin.
So that was done in the hospital by a senior physician, but they then thought that the Solumedrol would help him recover in his current status.
I must tell you,
Yes.
whoever did it, that's not true. It might make things much worse. And
Okay.
I don't know if you read recently that the claims for HCQ have been negative absolutely and completely. As a matter of fact, a couple of Indians had given a paper in the landslide, showing database how,
Right.
I don't know, showing that the HCQ was effective. Do you know the paper was withdrawn because it was fake news? So please,
Yes, sir.
HCQ is not to be used. And I don't know why azithromycin also was used. I think the diagnosis is it's very important to know that the COVID test may not come positive on the first, second day. But if you have lung changes at this point in time, in this setup, in this scenario, I think definitely COVID is first on the card before you think of any other condition producing lung. May I tell you, and this is so important for everyone, something that Zari passed on to me recently yesterday, that the COVID can be passed on. For example, when you sneeze or when you cough, when you have large droplets. When you have not so large droplets, they gravitate to the ground. When you have a little smaller than those, they may hit the back of your throat and you have your natural defenses protected. But unfortunately, the COVID virus also is passed out in normal breathing. That's the most astonishing thing that's been shown. Normal breathing and normal talking. And these are very small microns. You follow? In very small microns. And therefore, when you inhale them, they go straight into the alveoli and produce a pneumonia. So it's so important to remember to wear a mask, and a good mask. Because as I said, if a man who is carrying it and who is asymptomatic, and he talks and he breathes normally, he could still be putting out COVID virus. So that is the important thing. The not so small viruses can settle down on objects and there it may remain for 5 or 6 hours. But when it's very small, less than 4 microns or 5 microns, it goes straight into your alveoli and produces a pneumonitis. So that's the most frightening thing. And that is one reason why the disease is that infectious. That is the most important point for everyone who's listening here to. And that reminds me why the influenza epidemic in 1918, 1919 killed over 80 million people. The same reason. You know, the small ones, for example, which you do not inhale, might remain in the atmosphere for a length of time and by gusts of wind may be carried to places. And if you happen to inhale them, you could still get the infection. So that is the single most important thing I think we should remember. And I think Solumedrol is not indicated, HCQ is not indicated, and azithromycin is not indicated in this individual. You give oxygen. And of course, you give other therapy depending upon how hypoxic and how bad the. Okay.
Thank you, sir.
Okay, so we'll go to some radiology now. I have Dr. Samir Kapadia, who's going to show us a couple of X-rays specifically to COVID.
Hi, thank you very much for inviting us, and really proud that I'm with my teacher, Dr. Farooq Udwadia. X-rays, though less sensitive than CT, is typically the first line of imaging modality that one uses for a patient, especially one with suspect COVID. The most frequent findings are the airspace opacities, the alveolar opacities, what one sees as consolidation, less commonly called as ground glass opacities. They are usually bilateral, peripheral, and having a preponderance for the lower lobes. In contrast to the parenchymal lesions, the pleural effusion is pretty rare. Next slide, please. I'm not going to talk much on CT because Dr. Anirudh Kohli is there, but there are certain slight changes which we see on the CT, similar to the X-rays, but coming up much, much earlier. These are the ground glass opacities. These are the crazy pavings and organized pneumonias. Next slide. Sarah, next slide, please. Okay. So these are the signs that we see very frequently.
I can't see one half of your. I can't see one half of the CT.
Sarah, next slide.
No, I think they've.
Oh, okay. Okay.
Yeah.
Thank you, Dr. Kapadia, for those lovely X-rays and telling us that, you know, how diagnostic X-ray could be in picking up COVID when done at the correct time. We have Dr. Anirudh Kohli, who's going to speak to us about CT scans and COVID-19.
Good afternoon. I just get my screen on. One sec. So I'm in Mumbai.
Huh?
Mumbai, sir.
Hi. Very good. Where have you been?
I'm here, Mumbai, sir.
I haven't heard of you from the last 4 or 5 days, you know.
Get this screen on. Is my screen on?
No.
Are you able to see the
Not yet,
screen?
Anirudh.
No.
Okay, sorry.
Yes, I can see you now.
Yeah, you can see me, but I need to get onto images, sir.
Okay.
Because
your image only just now.
Go to the next one and see. Go to the next one. Yeah, go to the next one. Yeah. That's
okay,
fine.
they've got the screen up for me. Okay, fine. Okay, you can do it full screen. Okay, so the images now you're seeing? The image, yeah, thanks. So basic issue that today we have is the diagnosis. Does imaging help in the diagnosis? And for that, we need to look at what's the gold standard today. It's considered RT-PCR. It's got a maximum sensitivity of 70%. And that's really between day 5 and 7 using the nasopharyngeal swab. Prior to this may be negative. Post day 7, the sensitivity drops. So one disadvantage that we have with RT-PCR is a high false negative rate. It also has a long turnaround time of nearly 24 to 72 hours. And we also see inconsistent availability of testing today. Next slide. So we really need to have a systematic approach to a diagnosis to be applied, especially where we see areas with high prevalence, because the key is quickly to identify suspicious cases and to isolate. Next slide, please. So imaging really helps in supporting diagnosis. It's not a diagnostic tool, but supports diagnosis where we can really help to triage patients. And of course, once we have detected disease process, it helps in the determining the severity, guiding treatment, assessing treatment response, and also prognostication. Next slide, please. So CT chest is very sensitive to demonstrate alveolitis, and we've seen that from ILD and other pathological processes which involve the alveoli, and viral pneumonias are picked up very well with this sensitivity. CT with a positive RT-PCR has a sensitivity of 90 to 97%. In fact, in the Diamond Cruise, sorry, go back, please. In the Diamond Cruise ship where everybody was captive, they actually found that 54% of asymptomatics have positive CT findings. Its specificity is lower because viral pneumonias, other viral pneumonias, chronic eosinophilia can look similar to this. But what we need to remember is that the CT chest may be positive before the RT-PCR is positive. It may be positive when the RT-PCR is negative, So false negative RT-PCR, positive CT, which is very useful. And of course, it can be negative with a positive RT-PCR. We need to remember that. Next slide, please. So it's where we are finding it very useful is that it's becoming very useful in triage. With the RT-PCR report taking anywhere from 24 to 72 hours, in that much time, one, the patient can deteriorate without treatment or without support, oxygen support. Second, not being isolated, they may spread disease. So it's becoming very useful in triaging who to isolate and what to do next. Next slide, please. So the main imaging findings, as Samir said, is basically ground glass densities, which can progress to consolidation. And these are typically seen in a subpleural peribronchovascular location. They are often bilateral, but we do even get unilateral involvement. Next slide, please. So this is a typical CT of somebody who's has COVID, where you see diffuse ground glass densities in subpleural locations. You see septal thickening and diffuse areas with some patchy sparing. Next slide, please. And we see a range of appearances, the green arrow demonstrating diffuse ill-defined ground glass densities, the red arrow areas with consolidation. Next slide. Another case where the changes are subtle, the green arrow pointing out areas of ground glass density, but subtle involvement, but very specific because very subpleural. And in this current scenario would be quite specific to make the diagnosis. Next slide, please. And sometimes what we really are afraid to see is this type of a CT at presentation where there are dense consolidations. And when there are dense consolidations and extensive involvement of the lung, these are the patients who generally do badly and are likely to go into ARDS. Next slide, please. This is just to show you a spectrum following up from 17th May, 23rd May, and then 28th of May, where you can see the ground glass densities to start with. They become consolidations, the disease process progresses, and then things settle down and the shadows start to clearing up. Next slide, please. Another example to show you that, again, the first image showing you early, where the early changes, and then as the disease progresses, you see consolidations coming up, and then the consolidations start to clear up with residual areas of organizing pneumonia. Next slide, please. So we now also have, as I said, that it's useful in diagnosis, useful in determining the severity, the extent of involvement, but also it has, and we're trying to evaluate a role in prognostication, where we have a CT pneumonia software, which actually determines the extent of involvement, whether it's ground glass, whether it's consolidation based on the HU values. With that, we get an extent of involvement of ground glass consolidation as a percentage of involvement or actual ml of lung involved. For that, we can get a ratio of ground glass to consolidation and gives us something which calls an opacity score. And more consolidation, we have a higher opacity score, and we're finding these are the patients who are tending to do not so well. Next slide, please. And this is just to show you how the software segments out the different areas which are abnormally involved. Next slide. And it gives us a lot of data and numbers, but on the top, as you see, there's a total opacity score and a percentage of opacity. That means a percentage of the lung, that's 36% involved, total opacity score, which tells us how dense the involvement is. Next slide, please. And it's quite nice because we get these nice colorful pictures which show you the areas of involvement. So green is normal lung and red are the areas which are involved. Next slide, please. So this is just a spectrum of cases going from very minimal involvement to quite extensive involvement, showing you different areas of involvement. So this is something that we're playing with, and we're hoping to have see how they pan out clinically, whether this will be something useful or maybe just colorful pictures. Next slide, please. So in conclusion, CT is helping in supporting the diagnosis, especially in triage, and this is really where we feel CT is making an impact. Of course, with any disease process, helps us with the severity, then guiding treatment, assessing treatment response, and now we're looking at prognostication. Thank you very much.
Can we ask a question?
Yes.
Can we ask a question?
Pratik, can you just share my screen? I want to add 2 more points, please.
Yeah, Sarah. Sarah, please share Dr. Kapadia's screen. This one is okay, Dr. Samir?
No. This is not my screen. Okay,
this one is yours.
If it's troublesome, we'll just talk about it. And as Aniruddha just rightly said, that artificial intelligence is playing a very, very big role in picking up subtle lesions which are not seen on the X-rays and prognosticating them even on CT. Ultrasound, especially the point of care ultrasound, also helps in not only not picking up, but we can pick up a lot of small subtle things which are subpleural. You can pick up consolidations which are there. You can pick up these A lines and the B lines, curly B lines, which we see on the X-rays. We can see even these B lines on ultrasound, which replaces the normal A lines. And when we see the reappearance of the A lines, that is a very good prognosticator saying that the patient is on the way to recovery. So sooner or later, AI is going to come in a very big way. It won't replace radiologists, but radiologists who use AI will replace radiologists who don't use AI.
Lovely points. Thank you very much. Sir, you wanted to ask some question, Dr. Udvarya?
I just wanted to ask Anirudh two questions. The first question is, in the very early patients that you see with COVID infection, don't they resemble very markedly the H1N1 infection involving the lungs, subpleurally?
Absolutely, sir. Just like the viral pneumonias, it's exactly a carbon copy picture of what we saw with H1N1.
And if you remember one patient that we had, who was on a ventilator for a long time, who started with these subpleural lesions and ended up with more or less severe ARDS,
yes,
is very much similar to what you get. Is there any difference according to you?
Sir, not really. One difference is there is that we saw so few H1N1 compared to the number of COVID CTs that we are seeing today. Across centers today, we have a WhatsApp group where we actually see about 100 scans in a day between different centers. So we are seeing a lot more than what we saw with H1N1, but it's very similar. But the consolidation and its whole progress that we are now able to see, well, it starts off as ground glass, as you say, progresses to consolidations, they resolve, and then some of them progress even further to whiteout lungs and ARDS.
And is this a resolution of the lung that you see here?
Yeah. So in the resolution, the lung is some of them totally clear up. Some we see atelectasis, fibrosis, and some we see as organizing pneumonia, peribronchial consolidations. And I guess it's so early in the process. In a month or two, we'll see really what happens to those areas of organizing pneumonia.
The final question, Anirudh, without attempting to be rude, how would your intelligence compare with artificial intelligence?
So I think artificial intelligence is helpful, but as far as the X-rays go, we have used about a couple of artificial intelligence softwares which have been touted in the media elsewhere, and we put them to test with 100 positive COVID positive X-rays and 100 negative, and it came a cropper. So I think human intelligence will stay. Artificial intelligence may help us achieve things a little faster.
Yeah. Also, if you rely too much on artificial intelligence, you must realize that your intelligence will atrophy.
Okay, thank you very much, sir. I think some clinical treatment points people wanted to know. So some laboratory tests that can actually differentiate until the swab comes positive between another pneumonia and a COVID pneumonia could be the respiratory biofire swab, which will pick up non-COVID pneumonia, non-COVID-19 pneumonias. LDH, ferritin, and D-dimer, they go high in almost all patients with COVID-19 pneumonia. Another question that, and the treatment modalities, if we have injection remdesivir, an antiviral, which is intravenous, we have a capsule called favipiravir, and we have other interleukin-6 inhibitors like tocilizumab and itolizumab, which are available. So some question is that, is there an interplay between a flu vaccine and COVID-19? That means, can a flu vaccine, a quadrivalent flu, prevent COVID-19? I'm sure the answer is no, but if you want to elaborate, sir.
What? Didn't get your question.
The question is, if you've taken a flu vaccine, is there a diminished chance of getting COVID-19? And second part to that is, with the COVID-19 era, is it still okay to take a flu vaccine? That's a couple of questions that I've got on my question bank.
Yeah, I think it's impossible to answer that question. And they're trying out the Oxford vaccine, as you know, in a huge population in Brazil, where there's a tremendous infectivity of this COVID virus. It's to be seen, most important of all, not only the clinical aspect of it, but how many of them develop antibodies. Another interesting thing that Zari told me was that all of them were tested for antibodies at the Hinduja hospital. Those who are actively looking after the COVID people, including the ICU people, the house staff, the registrar, though they have been exposed for this length of time, not a single individual had any antibodies to the COVID virus. So that's so interesting because it shows that though you are exposed to this extent, one would have thought that you might have had a mild infection, carrying a mild infection to which you would develop antibodies. But it is interesting that in spite of that much exposure, not one of them, not one of the so many house staff, all of them, in fact, none of them showed antibodies. So the point is, to what extent will the antibodies form with the vaccine? That's the first question to answer. And they have shown, at least in studies where antibodies have been examined, that not more than 3.5% or so have developed antibodies. So the question arises, do you have a vaccine which will give rise to a sufficient degree of antibodies? And the next question is, how long will these antibodies remain? That's the next question. Is it possible, therefore, that you could get a repeat COVID infection in time to come? So these are unanswered questions, and these are vital questions really, because they really involve great problems for public health. If there are no antibodies coming up, or very few antibodies coming up, or if the COVID could attack you again, even if you had it once, that would be a dilemma indeed.
Also, the antibody testing kits that are available globally have shown a sensitivity only from 18 to 40%. So it's a very poorly sensitive test. That means you may have to do it twice or thrice to really know whether you've got an IgG.
I don't know what the sensitivity of the antibody testing they have done abroad. I'm not sure about that. I'm sure it's better than what it is here. But there also they have found, an antibody titer, of not more than about 3 to 5% of people.
That's right. So it's 18 to 40% at max. So the antibody detection is very, very low. I think we've finished with the cases. I'll ask Dr. Anil Mehta.
Pratik, I've got a question for sir. Pratik, can I ask a question to sir?
Sure.
Sir, we have observed that patients who are active TB patients on treatment don't have corona. How important is that, sir?
Sorry, was you asking?
So his question is that there is, the radiologists are humming all around that people who are on anti-tuberculous treatment, active anti-tuberculous treatment, somehow do not get COVID-19 infections, or the incidence is less. Any light on that?
Among whom? Among
patients who are on anti-TB drugs.
Anti-what? Anti-TB.
TB coughs.
No, I have no answer to this question, but I don't know whether this could be true. These might be random observations. You can't make a really scientific statement on random observations. I wouldn't think.
Similar is the case with patients who are on, who've got autoimmune diseases. Somehow they are presenting all over the world less with COVID-19. So we need to answer these questions only after we get enough data. Dr. Anil Mehta will take over and ask questions from the question bank and audience. Dr. Anil Mehta there? We can't hear. If he's speaking, we can't hear.
He's muted.
He's muted. His volume is off.
Anil, unmute yourself.
We can't hear. He's far away from the mic. Unmute.
Yeah. So we had a fantastic session and probably continuous streaming of so many comments and so many questions are there. In fact, sir, when I am looking right from the treatment of EB virus, the typhoid testing, as well as the amoebic liver abscess, so many questions are there. So what I felt, sir, that we'll require a full another session and we lost a valuable time in the beginning with technical. So I was just thinking the last question everyone has in mind and we wanted to conclude is, can we just streamline a small treatment charting or an algorithm for COVID patients? If that is fine, and then we can conclude. Otherwise, I cannot take the other questions, sir.
So you want to do that? Unmute yourself and do that, sir, for COVID-19 treatment. Dr. Udwaria, sir. Unmute yourself, please, sir. Yeah.
Huh?
Treatment for COVID-19.
Sir, can we have a COVID-19 treatment algorithm?
What? I can't hear the.
I will tell you. COVID-19 treatment algorithm for family practitioners, sir.
For family practitioners, no, nothing at all. You shouldn't be treating them, because if at all you are giving drugs, these drugs, A, are extremely difficult to obtain, and B, the patient should be in hospital. And C, you shouldn't be treating patients who are just positive for COVID unless there is involvement of the lung. And that too, if the involvement of the lung is not minimal, because the first treatment that you use in these patients is to just give them high flow oxygen and leave the treatment to the intensive staff. For the practitioner, no, nothing.
Okay, so I think I can just elaborate. We have many drugs that have been studied in the pipeline: dejected, hydroxychloroquine sulfate, azithromycin. We have the antihelminthic, which is ivermectin. We also have ivermectin. We also have some drugs orally like favipiravir, which is an antiviral, which may be soon available in the market. And then we have for in-hospital treatment, antiviral specifically, which is a nucleotide analog called remdesivir. When these patients go into a flare or when they release massive cytokines, that's the time we use cytokine inhibitors or interleukin-6 inhibitors. Most of our patients in the hospital are on low molecular heparin because studies from Lombardy and Italy and postmortem have shown that they get actually thrombosis, alveolar thrombosis. That's the cause of death. So most of them are on low molecular heparin in the hospital.
And if I may add,
please, sir.
The nature of the lung involvement that you have is not necessarily that of the usual ARDS. This has been spoken of by Gattioni, a very famous intensivist, particularly for ventilator therapy, he's an Italian, but working in Germany, who mentioned that there are two groups of patients. One group of patients in which the compliance of the lung is fairly good, where there is a ventilation perfusion inequality, which is fairly marked, and where the right to left shunt in the lungs, which you see normally in ARDS, is not very marked. Also, the lung volume is reasonably good. All points which point against the typical ARDS. And he mentioned that in these people, if you ventilate them on the principle of ARDS, you will lose them. And that's one reason why they had noticed such a high mortality of 80% or more initially on ventilated patients. So if you can find out if the compliance is reasonably good and the lung volume is not shrunk, then all that you need to do as far as possible, keep them on high flow oxygen. You come to a point, this is intensity, you come to a point where the patient becomes extremely breathless with a respiratory rate perhaps exceeding 50 or so.
Sorry. I missed
They
you.
need to be ventilated.
Okay.
Please mute yourself. Please mute yourself.
At this point in time, you can use a larger tidal volume than what is asked for you in the ARDS network trial. And most important of all, you must not put them on high peak. And this is, I think, what they have been doing in the British County Hospital. And I think that is one reason why the mortality, by and large, is not much. But ultimately, these two groups, the one with the good compliance may go into the ARDS. And there are some who come with just plain ARDS, in which case they are to be treated in the same way as the ARDS network.
So this is a subtopic called happy hypoxia. So they have hypoxia, but they are not tachypnic and their saturations are low. So as Sir correctly says, you should not ventilate them, put them on high flow oxygen as early.
They may need ventilation, and how would you know that? I mean, how would you know that their compliance is good? You may not be able to detect that ordinarily. If you had a transesophageal balloon, you would detect that by the marked negativity of the intrapleural pressure. But if a person is breathing at the rate of 40 per minute, such a patient, in spite of high flow oxygen, I think you will need to ventilate. And the principles of ventilation are that.
That's what tachypnea, yes.
Thank you.
Okay.
Thank you. Over to Dr. Jawahar.
Jawahar.
So thank you for taking your time off on a Sunday morning and addressing almost 400 plus people today. Let me assure you on your comment that our intelligence should not atrophy. We have made sure today at least that it has been stimulated appropriately to not atrophy. Thank you so much. Thank you all the associations that have come together today to help us organize this function. To our President, Dr. Vijay Kambati, Anil, to Dr. Prateet Samdani, and to all the speakers who participated. And of course, to the audience who took time off and are still there. I can see all of them. None of them have budged from the screens. And finally, to one young lady who has been the backbone of this all, Sarah. Sarah, present yourself on the screen if you can and take a bow.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you very much.
Thank you very much, sir. Thank you.
Thank you very much.
And a very good day, sir. Thank you. Thank you all. We leave.